Yes, so thank you very much for joining us again today. For those of you who are joining us for the first time, I am Dr. Lesego Mawela, and I'm the one who usually facilitates this evening session. Yeah, and thank you for joining. Today we are looking at pregnant women living with HIV and AIDS, and particularly I will take you through the journey, of a pregnant woman. But importantly, I want us to really zoom into issues of high viral loads, and then so that we are able to then know how to manage these women. All right. Yeah, we are starting a bit like 2-3 minutes late. So I think we should start. Just to say that if you are interested in some of our training programs, we have a special, that's going to end on Monday. So please do make time to participate in that particular program. All right. So for today, our focus area is going to be, let me close this, yes. For today, our focus area is to look at how to manage a patient with a high viral load, but also just to look at what assessments need to be done, particularly to pregnant women who have high viral loads. So that is going to be our focus area. So let me continue from there. So here is a case. It's a case of Maria. Maria is a 34-year-old female who presents for antenatal care services. This is her first visit. And on examination, she is estimated to be 5 weeks pregnant. She expresses some interest in counseling and testing, and you offer her HIV counseling and testing for that day. And then here's the first question for you for today. So her screening test, right? For her screening HIV rapid test is positive, right? If you have tested a patient and the screening test is positive, what would you like? What do you think should be done if someone has a screening test that is positive? What would you like to do, right? So for those who are joining us via the live Facebook, you may type in your views, but if you are joining us via Zoom, you have some options to select, and then we will take it from there. Thank you. All right, let's all participate. If a patient presented and a screening test was positive, how would you then proceed from there? All right. So let's then look at what some of you are saying. So some of you are saying you must give a post-test counseling. Yes, that is very important. I see the Tebogo Piri on our Facebook page. You are saying you must confirm the results. Yes, because this is a screening test, right? Remember, there's a rule. You should never diagnose HIV with one test. So those of you who said start the patient on ART, that is not, we are not yet there, right? We have the first test that is positive. So it's very important that whenever you test a patient for HIV, you become patient. You have to wait for the result of the second test. So those of you who said confirmatory test, TB screening, I mean, it makes sense, Sister Daguse. So that is fine, but we are not going to start ARVs, and we are not going to do any baseline tests at this point in time. The key really is to do post-test counseling for this patient and also provide a confirmatory HIV test. So that is important in terms of where we are, right? So also it's important that whenever you deal, remember she presents and she's pregnant. It's important that you don't just focus on the HIV status of this mother. It's important that you look at her in a comprehensive way, considering the basic antenatal care plus services, which would include issues like proper history taking, medical history, obstetric history, physical exam, BMI, MOAX, and then some of the tests that you would have to do, your HB, your RPR, but the key message here is that whenever you see an HIV positive pregnant mom, don't just focus on the HIV care. It's important that you provide, a comprehensive answer. And I see Pelu there, you are saying post-test counseling, confirm the status, stage here, but it's important that we confirm the results. I think that is very important. The key thing is don't diagnose HIV with one test, right? So provider initiated counseling and testing is very important, and it should be provided to all women, irrespective of whether they are pregnant or not. But if they are pregnant, we want to we confirm the HIV status. We ensure that the women are booked. We don't do 10-aways where we say, no, we see pregnant women on Wednesdays, come next week. No, we do not do that, And if the test is negative, you would want to retest her every subsequent visit during the current pregnancy. That is very important. You also want to ask about her partners, especially sexual partners. You also want to ask if she's got other children at home who might need to be tested, and that is very important. Remember, if you do confirm with a second test that she is positive, you would then need to act and follow, the testing algorithm that we use in South Africa. So here's the testing algorithm that we use in South Africa. Firstly, for now, in terms of our case scenario, we did a screening test, right, which came back reactive, so it was positive. So we are here, right? We are not yet at a state where we can initiate the patient on ARVs. So if we have that, then the next step is to do a confirmatory test. So that is a second test. If you've got two tests, so now your screening test is reactive and your confirmatory test is reactive, you now have two tests that are positive. You can then confirm the HIV status of your patient to say the patient is positive, and you would then need to act, as needed. Just remember that if the HIV result is negative in pregnancy, we have to continuously retest the women, and then because we don't want any woman to seroconvert during pregnancy. All right. So here we are again with Maria, who is 5 weeks pregnant. We did the screening test, which was positive, and now the confirmatory test for Maria is positive, right? The confirmatory test is positive. What is your action now? You've got two tests that are positive. The first screening test was positive, and then also the confirmatory second test is positive. What do you want to do? What is your next action for our case scenario? All right. So in pregnancy, a positive HIV test is very important. We take it very seriously. We treat these women as urgent. We don't want to delay anything in pregnancy, because there's also a third party or a second party. Yes, obviously the sexual partners are also parties because we want to bring them on board, but we also have a huge interest in the unborn child, because we want to really have children who are not living with HIV, So yes, number one, you would provide post-test counseling. Pindile Kubisa, what do you think? Because I see you have joined us there. Morongwa Makura, Kilebuhilo Poloholo, you guys you have joined us via Facebook. You must type in your answers there. Pearl Semenya, what do you think should happen? Try to I can see all your answers, so don't be shy to participate. So I see Mpo saying, yes, you confirm you must provide a post-test counseling, do your baseline tests, and Mpo has given us some of those baseline tests like your sputum, your gene expert, and then also Mpo says start ARVs. So I mean that is quite very important, right? I see Lemo, Loena, you are saying do a gene expert, very important in pregnancy. So let's summarize it this way. You do your post-test counseling, right? That is a tick. You would do your baseline test, which is usually your CD4 count and your and a creatinine level, right? Lemo, just remember we don't do baseline viral loads in pregnancy. Our first viral load is done when the patient has taken ARVs for 3 months, if it's a new patient like this one, right? Same day ART initiation, yes, that is very important, and I see other people are also mentioning that, so that is key. Basic antenatal care, start ARVs after 7 days. That is the thing that you will never do, right? In pregnancy, we want to start ARVs same day. Once you have confirmed the HIV status, it is an opportune time to then start your patient on ARVs. So yeah, so those are some of the things. To summarize, post-test counseling, track sexual partners, very important. Ask about the children, very important. Do your baseline assessment, start ARVs, and then take it, from there. So those are some of the things that you would do. So just to summarize some of the things, remember in pregnancy, you have to do your basic antenatal care. So don't forget that package of services. In the HIV world, you also have to assess her whether she's eligible for cotrimoxazole prophylaxis therapy, for isoniazid prophylaxis therapy, or for even fluconazole prophylaxis therapy. This is very important, right? We will stage her, WHO staging, and also do a baseline CD4 count. We have to screen for TB and then treat any other opportunistic infections that she might have. Let's not forget the psychosocial implications of living with HIV, especially a new diagnosis in pregnancy. We have to ensure that she is supported, she's informed, but she's also encouraged to disclose to at least someone at home so that she can get good social support. So that is very key. Then also make sure that you do a proper history, you examine, you do your baseline tests, make sure that your problem list is written nicely, especially for women who might have been, had some bad obstetric history. So let's not forget the pregnancy issues and only manage HIV at this stage, right? So this is just a table from the guidelines that also summarizes, routine care for people who are being started on ARV. So it says here, determine the clinical response. So very important. We have to check for weight all the time. If this was a child, we'll be checking for growth and neurodevelopment, but for adults, a BMI is sufficient. We have to screen for TB and other opportunistic infections. You have to do your WHO stage. You have to screen for pregnancy, and she is pregnant, but then we have to ask about the future pregnancies, previous pregnancies. These are some of the baseline tests that need to be done. A CD4 count is very important. A viral load is not a baseline test. So this is very crucial and important. So these are some of the things that we need to check in terms of your WHO stage, right, which is very key. Remember that WHO stage 1 patients are asymptomatic, right? And I see Mpo, you're asking, doctor, you just mentioned cotrimoxazole in pregnancy. Please go deeper. So it's very important. We are still going to get there. There's a slide when I'm going to address the issue of cotrimoxazole. But even with cotrimoxazole eligibility, you have to know how to stage your patients. So if you've got a patient who's asymptomatic, that means they are HIV positive, they have no complaints, they have no other issues, you will classify them as stage 1. If they have skin conditions, your herpes zoster, shingles, things like herpes, blisters on the mouth, those are generally stage 2 conditions. Or a patient who has lost weight but less than 10%, we would regard this as stage 2. Stage 3, things are getting a bit worse. You've got things like pulmonary, TB, oral candida, oral helicobacter, and the weight loss is significant, more than 10%, right? Stage 4, we are talking about very serious conditions. So extra pulmonary TB, that is TB meningitis, TB of the joints, pneumocystis jirovecii, or what we call PCP, which is prevented by giving cotrimoxazole, toxoplasmosis, kaposit. So these are very bad conditions. Invasive cancer of the cervix is a stage 4 condition. So even in pregnancy, you have to take proper history, examine the women, and then ensure that you are able to stage your women, right? So when do we start ARVs? So you'll see that we say fast track same day, who? Pregnant women and breastfeeding women, right? And it's important to know that even if we say you fast track, once you start them on ARVs, they should remain on ARVs for life. So it's not like we're going to start and after they deliver, we stop the ARVs. No. And remember, the fast tracking same day is very important, that we don't just rush and initiate, but we also support our women. We make sure that they are also psychologically ready, right? If you find that there's women who are very, very sick, she's got TB meningitis or cryptococcal meningitis, you might need to delay the start of ARVs for at least 4 to 6 weeks, at that point in time. But all in all, most pregnant women, as soon as they are diagnosed, they should be started on ARVs same time. So that is very, very, very important, right? So for in pregnancy, it's same day ART initiation. That is what we want to do. All right. And here are the drugs, right? And the only thing I want to tell you, I don't want to try and teach you all the drugs, tonight, but it's just to tell you that by God's grace, all the drugs now are relatively safe, or they can be used in pregnancy without having a lot of concerns, including dolutegravir. So really, that is what we want to do. So when you classify ARVs, you classify them as reverse transcriptase inhibitors, your NRTIs, and basically we've got 5 of them, from tenofovir, abacavir, zidovudine, lamivudine, emtricitabine. Whenever you formulate a regimen, you should at least have 2 drugs from this class of drugs, right? Just remember, tenofovir is the commonly used one as a 300 milligram daily tablet. And it's important to know that in non-pregnant patients, we use a creatinine clearance, but in pregnancy, we use just a creatinine level in the blood, right? Okay, so there you are being asked whether you hear that with TLD. So yes, TLD has a combination of tenofovir with a lamivudine and dolutegravir. Dolutegravir should now be prescribed. We should initiate all women who test positive, whether on family planning or not, whether pregnant or not, whether in first trimester, second trimester, third trimester, all women, right? So dolutegravir is now the recommended drug to be used for adults, children, pregnant and non-pregnant women. So that is really our drug of choice. T for tenofovir, L for lamivudine, and D for dolutegravir, right? So that is what I wanted to really say, that it is now safe in pregnancy. However, you should always check for drug-drug interactions to ensure that you are doing safe initiations, right? So in terms of our regimen, our preferred regimen for initiation is a combination of tenofovir, lamivudine, and dolutegravir, right? Very important. So Ausletter is asking there, what is the difference between creatinine clearance and the creatinine level in pregnancy? So very important. A creatinine clearance is a calculation that you do. It takes into account the level of the creatinine in the blood, but also the weight of the patient, right? And it is abnormal when it is below 50, right? A creatinine clearance, going back there, right? A creatinine clearance, which is a test we do for patients who are taking tenofovir, is abnormal when it is below 50. Very important. But in pregnancy, because the weight is exaggerated, a creatinine clearance is not reliable. Is not reliable, right? So we take your creatinine. When you do your UNE, they give you a creatinine level there. We look at that. What is a creatinine? It is the breakdown of protein. So the amount of creatinine in the blood, and it should not be more than 85. It should not be more than 85 in pregnancy. So that is important, right? We will still deal with it again later on. So in pregnancy, we check the creatinine level. And then for non-pregnant adults, we check your creatinine clearance. This table here is very important. And just to say that whenever you prescribe ARVs, you should always prescribe 3 ARVs, which is a combination of an NRTI plus an NRTI plus a choice between your integrase inhibitor, your NNRTI, or your protease inhibitor. Our NRTIs, we've got tenofovir, and then that is the first choice, right? Where tenofovir cannot be used, your second choice becomes abacavir. Where abacavir cannot be used, then your option will be zidovudine. But in a patient, an adult patient who tests HIV positive, the majority will be started on a regimen that has tenofovir and then lamivudine and then with dolutegravir. Like I said, dolutegravir is now the preferred, right? We love this drug. It is good. It is potent, less side effects, very potent in terms of the time it takes to suppress the viral load. It's got a high barrier to resistance, so it's a very good drug, right? And we want to make sure that 99.9 of our patients who are stable without any problems are initiated on tenofovir with lamivudine and dolutegravir, right? Where you cannot give dolutegravir, maybe there's significant drug-drug interactions, as an example. That's where you can then consider efavirenz if it is safe to give it. For patients who have active psychosis, mental health, unstable, right? We would then consider lopinavir, ritonavir. So this table sort of helps you also in terms of how you switch your patients and so that you make the right drug switches for all your patients. So this is very key, right? So I hope you are following on that one. So I know you think that maybe if DTG is now safe, we don't have to talk to women. No, that is not the case. We should not go back to an instance where we used to believe that we know best. It's important that we see our patients as partners in their care. They are involved, they are empowered, we give them information, they are involved in every decision about their health, right? So for every woman that you see, you always have to make an intention to understand her current pregnancy status, but also her future plans, whether she is planning to fall pregnant and when exactly. Because in terms of PMTCT, we always prefer women to fall pregnant when they are healthy. Very key. When the CD4 count is up, the viral load is suppressed, and also whatever opportunistic infections they might have, we want to get a chance to at least treat this opportunistic infection. So we don't want women to fall pregnant when they are clinically unstable, right? Zoom user, you are asking there, so DTG is now safe in pregnant? Yes, it no longer reduces the risk. It no longer increases the risk. That's what you are asking. The question is, the answer is, dolutegravir is now the preferred drug to be used for whether you are a woman or you are a male. whether you are on family planning or not, whether you are pregnant or not. And in pregnancy, in all trimesters, dolutegravir is now regarded safe because it is comparable to efavirenz. It has not been shown to increase the risk of neural tube defects. So very important, right? So both dolutegravir and efavirenz are now regarded as safe in pregnancy. They can be used. However, we prefer dolutegravir because it has a better side effect profile. It is potent. The time it takes to suppress the virus is very quick. And in pregnancy, that's what we want to achieve. And then there are no drug-drug interactions with contraception. So women who are taking Depo, Nestrate, they shouldn't be worried that they might have contraception failure because they are taking an ARV drug. So DTG is the best in terms of what I've just explained, right? And then even if it is safe and if evidence is safe, we still want to integrate with sexual reproductive health services and ensure that we offer family planning, to women, and so that all pregnancies are planned. And before women fall pregnant, we ensure that they are optimized, they are healthy at that point in time. All right. So I'm hoping you are following in terms of that. And then also we prefer what we call fixed dose combinations in pregnancy because we don't want people to take a lot of tablets. You enhance adherence through your prescribing habits. So that is very important, right? So if you look at the first bullet there, it's what we call TLD. It's one tablet that has 3 drugs. What are these drugs? It's tenofovir, lamivudine, and dolutegravir. So it's TLD. And we want the majority of our patients to be on this regimen because it is the best combination that we have in the country. Where you've got challenges with DTG, maybe your patient is taking other drugs that might interact with dolutegravir, efavirenz becomes, an option. Therefore, you can still give a fixed dose combination that has TEE. But, and then we take it from there. Just note the other fixed dose combinations so that when your patient is not taking a standard fixed dose combination like TLD, you still use these other fixed dose combinations to minimize the number of tablets that you are prescribing to your patient. So that is very important, right? So I'm hoping you are with me. Now, cotrimoxazole and TB preventative therapy, these prophylaxis therapies are very important. Why am I saying so? Because they prevent very important opportunistic infections that can cause harm to both pregnant and non-pregnant patients. And in pregnancy, these prophylaxis therapies, if indicated, we should then provide this particular prophylaxis therapies. So number one, just to add that cotrimoxazole should be given in pregnancy in women who qualify. Now, today we are not talking about children, right? We are talking about this last line there at the bottom. HIV positive adults and children older than 5 years. So if you have a pregnant mom whose CD4 count is less than 200 or her WHO stage is stage 2, stage 3, stage 4, she should be on cotrimoxazole prophylaxis. So all HIV positive pregnant women who are symptomatic, WHO stage 2, stage 3, stage 4, should be initiated on cotrimoxazole prophylaxis therapy. So you'll prescribe the drug cotrimoxazole 960 milligrams per ounce daily, right? It's a daily tablet that they need to take, right? What about TB preventative treatments in this instance, right? So TB screening is important in pregnancy because it is the entry point for your TB preventative treatments, right? If a woman is pregnant and she's got TB symptoms, she should then be investigated. And if TB is confirmed, we should then treat for TB. Very key. If we screen her and she is asymptomatic, that means she does not have symptoms, and we assess for contraindications. And the key one that I want you to look at is a CD4 count, right? So in pregnancy, pregnant women with high CD4 counts, with a CD4 count more than 350, these pregnant women are not eligible for isoniazid prophylaxis therapy, right? In other words, in pregnancy, you want women who are asymptomatic, women who have a negative gene expert with a CD4 count less than 350. Then you can give them your isoniazid prophylaxis for 12 months. So that is very important, right? Yes, in this way, you are right. If we cannot give INH during pregnancy, we can then start this isoniazid postnatally during the 6 weeks visit after delivery. Very, very important. Just to remind you that the fluconazole prophylaxis protocol has been updated, and we no longer use this particular one, which said symptomatic, non-symptomatic. So if you are still using something like this, where you are giving, fluconazole 800, you are a bit outdated. So here is the updated algorithm as outlined in the guidelines, right? Firstly, it says that whenever a patient is HIV positive and they have a CD4 count of less than 100, you should then do a crack antigen test. So that is very important, right? If the crack antigen test comes back positive, right? We don't ask for symptoms. Yes, you say you assess for symptoms, but in terms of your clinical decision about whether you are doing a lumbar puncture or not, you should then refer your patient for a lumbar puncture immediately. In other words, all patients with a positive crack antigen in the blood, serum crack antigen, should be referred for a lumbar puncture, right? If the lumbar puncture result comes back and it says negative, right? So we have excluded crypto in the CSF. This then we can then start this patient on the fluconazole wing, the prophylaxis wing of this treatment, right? Remember, if crack antigen is positive in the CSF, it means this patient now has a meningitis and they should be admitted for at least 2 weeks. So let's start again. HIV positive patient, CD4 count less than 100, you check for crypto in the blood by doing a crack antigen. If the antigen is negative, there are no problems, you start ARVs. If the antigen is positive, this patient requires a lumbar puncture. Very important, right? If the lumbar puncture is negative, so the cryptococcus was found in the blood, but it is not there in the CSF, then you can treat this patient on an outpatient basis. And how do you treat this patient? You start them on 1,200 milligrams of fluconazole for 2 weeks. After 2 weeks, you reduce the dose to 800 milligrams for 2 months. After 2 months, you reduce the dose to 200 milligrams daily for at least a year. You should not stop the fluconazole prophylaxis. Never stop it until the CD4 count is more than 200, the viral load is suppressed, right? And the patient has taken fluconazole for at least a year. So this is very, very, very important, right? Remember, if the crack antigen in the CSF was positive, you would then refer this patient for admission in the hospital. After the 2 weeks, they would then discharge the patient for you to continue the 800 milligrams for 2 months, right? Very important. Please note that footnote there, that at this point here, if there's going to be delays in doing the lumbar puncture, start the patient on fluconazole 1,200 milligrams and still refer the patient for a lumbar puncture. So we don't want to create delays. Esther, you are asking there, Esther Mbuto, Hi, doctor. We refer patient for lumbar puncture even if there are no symptoms, headache. Yes, and that is the important change in the guideline. In the previous algorithm, we would have decided on symptoms. Now we are saying, regardless of whether there are symptoms or not, as soon as your crack antigen in the blood comes back positive, right? You should refer the patient for a lumbar puncture and still start them. You are allowed to start the fluconazole as you refer them for that lumbar puncture. So that is very important, right? And then Mpo, you are asking, so doctor, after a year when the CD4 count is below 200, we continue? Yes, you cannot stop fluconazole if the CD4 count is still below 200. So that is very, very important, Mpo, at that point in time. All right. All right. So yeah, and then remember when to start ARVs. Like I said, if cryptococcus meningitis was diagnosed, you would start the ARVs 4 to 6 weeks after treating your patient for 4 to 6 weeks. And then on the other side, if this patient had crypto only in the blood but not in the CSF, so there was no meningitis, you would start ARVs after your patient has taken fluconazole for 2 weeks, right there. So this is how you would then handle it. All right, great stuff. I hope you are with me there. I see there's questions about Zuki Swamadiwani. You are saying if you do a drug transition to an 8-year-old child weighing 26 kg, what strength of a Bakave would you give? All right, Zuki, so you need a pediatric dosing chart to determine that particular dose. And it's likely to be normal doses. Abacavir 600, lamivudine 300, and DTG 50 milligrams, in my view. Rabelani, if a patient got pregnant in 4 months or whilst on INH for 4 months, what must you do? Should you? So if she falls pregnant and you diagnose the pregnancy early, right? You can stop the INH, right? But if she's already 4 months pregnant, and she's taking INH, you're probably going to allow her to continue. Says later, you are saying if IPT completed after 12 months, then become a contact after 3 months, how do you do? Says later, I know that there's a new guidelines that are talking about the management of TB contacts, and they allow for isoniazid to be repeated. But the HIV guidelines for now do not talk about repeating IPT. We will have to wait for the final signed contact, TB contact guidelines, and then we take it from there. All right. I'm hoping you are still with me as we continue. I wonder if we will finish today's session, but there's always next week for us to continue. As long as at every point, we learn the important things that we need to learn. So here's Maria, right? She was then started at that point in time on tenofovir, lamivudine, and efavirenz. So this is what she was started on. So let's leave it at that. But in today's world, right, we would have started Maria on tenofovir, lamivudine, and dolutegravir. Her baseline CD4 count is 250. Her creatinine is 90. Gene expert is negative. She's okay. She has no complaints. You see, Maria is okay. However, she was started on TB treatment 1 month ago. So she's now on TB treatment and efavirenz-based regimen. She's, however, doing well. She has never missed any appointments, right? So there's a question about assessments. Oh yeah, this is a 3 months follow-up visit. So she's now 3 months pregnant, right? On ARVs, 3 months on ARVs, very important. She's doing okay, except that she was started on TB treatment. She's taking an efavirenz-based regimen, right? So there's a question there for you. During a 3 months, if a pregnant mom is on ARVs for 3 months, what are some of the tests and assessments that must be done? If you see a pregnant woman now who's HIV positive, right? Who's HIV positive on ARVs for 3 months. She's coming in for a 3 months follow-up visit. What are the tests that you would consider for her? Okay, Mafezi, she's saying CD4 count. Esther, you're saying viral load must be taken. Let me see what other people are saying there. Joyce, remember dolutegravir has no drug interactions with contraception, Joyce. So don't worry about TLD and implant. Everything is okay. Sarah Dawood, you are saying creatinine, viral load, and bank. Okay, I agree with you. Viral load at 3 months. Yes, that is true. Maggie, you are saying you want to understand the part about avoiding creatinine clearance. If the weight is above 55. Okay, so in pregnancy we don't do a creatinine clearance, we do a creatinine. So at 3 months you would do a creatinine test because the patient is taking tenofovir. That is very important. And if that creatinine is above 85, it is regarded as abnormal, and you'll have to discontinue tenofovir for that patient. A viral load must be done at 3 months for all pregnant women who are newly diagnosed and started on ARVs during the pregnancy. So that's very key. Basic antenatal care, yes. A CD4 count, no CD4 count. A CD4 count is only done at baseline when you start treatment, and then you also do it again at 12 months on ARVs. This is a 3 months follow-up visit for our patient here. And then we would have to then look at it in that way, right? So very, very, very key. So those are the assessments. Remember, you must do your basic antenatal care. Don't just treat HIV, treat the woman who is pregnant and ensure that the comprehensive care that should be given in pregnancy must be done. And you can see now, here's a list of tests on your left there. You've got a list of tests, and then there's a schedule to say when to repeat which one, right? Very important. Now, at 3 months, I want you to focus at 3 months. One, you must assess for side effects, you must screen for TB, provide support for adherence, encourage safe sex. You know, she's already pregnant in our instance, check her weight and BMI, do WHO staging, and then screen for TB. Hepatitis B is only done at baseline. A pap smear is done at baseline or at least 6 weeks after the pregnancy. A CD4 count is done at baseline, then at 12 months, so we don't repeat. A viral load, because we're talking pregnancy, the first viral load in pregnancy is done when the patient has been initiated on ARVs and it's during their 3 months visit at that point in time. We don't do a creatinine clearance in pregnancy, we just do a creatinine test, and it should be done during the 3 months visit. These other tests, you won't do them unless if the patient is taking that specific drug. For example, if the drug regimen had zidovudine, we would do an HB. If they were taking nevirapine, we would do an ALT. If they were taking lopinavir, ritonavir, we'll be talking about doing your lipid profile at 3 months. Our patient is taking tenofovir, lamivudine, and efavirenz, right? So we don't need to do anything else except a creatinine clearance, a 3 months viral load, and then all the other soft assessments that we need to do around side effects, adherence, you know, and so on, right? Joyce, you are asking how many times should we do a viral load during breastfeeding? Every 6 months, as long as it is suppressed. If it is not suppressed, you'll have to do it more frequent and decide, probably within a month. But if you're talking about a woman who is suppressed, every 6 months during breastfeeding, we want to do a viral load. All right. So very, very important as we take the journey of a woman. So this is what I was saying, to say if you have a newly diagnosed HIV positive woman who started on ARVs for the first time during the current pregnancy, the first viral load is done at 3 months when she is 3 months on ARVs. Very important, right? And if this 3 months viral load is done and it comes back suppressed, the next one will be done during delivery. Very important. However, we have women who are HIV positive, who fall pregnant whilst already on ARVs, right? So if a woman comes today, she's on ARVs and she tests positive for her pregnancy, you want to do the viral load during that day when you diagnose the pregnancy. So these women are different. There's the woman who is HIV positive, already on ART, she falls pregnant. During the day when you are diagnosing the pregnancy, you must do the viral load. If the viral load is suppressed, you will repeat the viral load at delivery, right? If a woman is diagnosed HIV positive for the first time during a pregnancy, we start her on ARVs first, we repeat the viral load in 3 months' time, and then take a decision based on the results. So these two women are very important that we must differentiate these women, right? Now, I want to then continue from there. I think that is fine, right? Now, remember our case scenario. She's taking tenofovir, lamivudine, and efavirenz, and then now she's got TB, right? She's got TB. So just remember your NRTIs. Which drugs are these? Tenofovir, lamivudine, emtricitabine, zidovudine, abacavir. There are 5 of them, right? They are metabolized in the kidneys, and you don't need to dose adjust those drugs whenever a patient is taking TB treatment. Dolutegravir, in the context of rifampicin, you should always remember to increase the dose, right, to 50 milligrams per os BD. Very important, right? Efavirenz, which she is taking, right, in the context of rifampicin, you don't have to do anything to that efavirenz drug. You just continue. It is safe with TB treatment. Nevirapine should never be given with rifampicin. So if she was taking nevirapine, we would have to stop that particular drug, right? Lopinavir, ritonavir, you have to increase the dose. You either double the dose if the patient is taking the tablets, or you prescribe the additional ritonavir, for both tablets and the syrup. So you have that option, which is very important. This slide is very important. And when we do cases in the NIMART program, I noticed that nurses struggle with the adjustments that you need to do, especially for patients who might be taking lopinavir, ritonavir. So just remember, you are only allowed to double the tablets. You should never double the solution. So if a child is taking 2 mils and they develop TB, you can't say, I'm going to give 4 mils. No, you still give 2 mils of your standard lopinavir, ritonavir. Then you prescribe your additional ritonavir to boost your standard dose, right? So it's important to know what to do in the context of TB, because rifampicin is a liver enzyme inducer. It activates these enzymes, and then they metabolize other drugs very quickly. Which drugs are those? Dolutegravir and lopinavir, ritonavir. So if a patient is taking dolutegravir or lopinavir, ritonavir, and they are also taking TB treatment that has rifampicin, you need to increase the dosage of DTG from 50 daily to 50 milligrams BD, or your lopinavir, ritonavir to a doubling of the dose if it's tablets, or even prescribing additional ritonavir for both tablets and the pediatric syrup. So this is very, very, very important, right? And yes, Zizile, virological, when you say viral load is suppressed, we mean a viral load of less than 50 now. So very, very important, right? And doctor, in July now, viral load was done in May, and it was lower than detectable. Remember, if a pregnant woman has a lower than detectable viral load, right? Your next viral load is during delivery, right? Then if the delivery viral load is suppressed, postnatally, during breastfeeding, you repeat the viral load every 6 months. So that is very important. Sani Madolo, you are asking, so doctor, you said you do a viral load at 3 months only. then do it again at delivery. Yes, that is correct. If the 3 months viral load is suppressed, right, the next viral load is at delivery. So that is very, very key. Sai, you're saying let's not forget about atazanavir, ritonavir, and TB treatment. Yes, so the effect of TB is for patients who are taking your protease inhibitors. And I must say at this stage, right, it's important that you pay attention to this, because if you do not make the right drug switches, your patient is going to fail ARVs dismally. So we don't want to do that. And Estama Mbuto, how do you dose the ritonavir in children? Esther, you go to your pediatric dosing chart based on the weight of the child. It will tell you. And the 2021 chart talks about the powder. So most children will be getting either 1 packet or 2 packet, of that powder. So that is very, very key. Lerato, you are asking, are we allowed to switch patients to second line for patients failing first line, or do we need to consult the doctor? It's all about your confidence. If you are confident and you have done it many times with the doctor, you are able to do it. If you're not confident, call your doctor, call your mentor, discuss the patient, and then from then onwards, you'll gain confidence over time. But NIMART nurses who are certified competent should be able to switch patients, especially patients who have high viral loads, taking an efavirenz-based regimen. All right. So very important. Zenkos, you are asking, what is the difference between taking a viral load in 3 months in pregnancy and 6 months for breastfeeding women? As these two women are not at the equal risk. Well, the risk is not the same, Zenkos, because you must remember the presumption is, firstly, even in okay, let me clarify something. When we talk about the viral load, when we say a PMTCT program, PMTCT starts when a woman, okay, I don't want to mess it up because I almost said when she falls pregnant. Ideally, it starts way before they fall pregnant, but I want to talk about the issues of viral loads. From the time she falls pregnant until the child is 2 years. What does this tell you? This means if you have a pregnant woman who tests positive during a pregnancy, right? You would start her on ARVs, you repeat the viral load in 3 months' time. So that is a tick. If that viral load is suppressed, your next viral load is done during delivery. I hope you are with me now, because I want you to get it right? She's diagnosed HIV positive for the first time during pregnancy, right? Let me go back, because I think for today we're going to stop there. You must join me again next week, because I want to clarify it nicely for you. Follow me carefully. You've got a pregnant woman who tests HIV positive for the first time during her pregnancy. You're going to start her on ARVs and repeat the viral load at 3 months, right? If that viral load is suppressed, the next viral load is during delivery, right? We are here. Is during delivery. If the delivery viral load is suppressed, you can see the green there. If the delivery viral load is suppressed, the next one is at 6 months, and you continue every 6 months, just like that, right? I want to give you a different pregnant mom. I mean, a different woman, so she's not pregnant. Here's a mom. She is breastfeeding. She tests HIV positive for the first time during breastfeeding. Are we together? She's HIV positive. She tested for the first time positive when she is breastfeeding. What do? You start her on ARVs. You repeat the viral load when? Not 6 months, 3 months. So, and it's the thinking you need to have, right? That in PMTCT, we don't have time. We want to ensure that women who are pregnant or breastfeeding, that they are all suppressed within 3 months of starting ARVs. So that's very important, that you understand that the issue of 3 months is not only during pregnancy, it is also during breastfeeding, right? However, once your viral load is suppressed, the 3 months viral load is suppressed, then your viral loads are every 6 months, which is very, very, very key for you to understand, right? So it doesn't mean if she tests positive for the first time during breastfeeding, you are going to do the first viral load at 6 months. That's too far. She is breastfeeding. She is feeding the child breast milk that has a high viral load, and that is what we really want to deal with, right? So Mandlas Kosana, you are asking if a patient completed TB treatment 6 months, do we still need to give 12 months of INH? Yes, Mandla. And why? Because patients who are living with HIV and AIDS, even after taking TB treatment, right, for 6 months, they still have this residual, latent, non-replicating TB that can become active TB later on. Remember, with INH prophylaxis, we are actually treating latent TB, right? That's why our patients, they will have TB, they are treated, then after 2 months, they have TB again. So our guidelines recommend that even patients who have recently completed TB treatment, we must consider them for TB preventative treatment when they complete TB treatment. Zizili, you are asking, so if a mother is having a viral load of more than 50 and wants to continue to breastfeed, they are supposed to be continued? Okay, Zizili, we're going to deal with this one as part of our follow-up next week, right? But in the principle of PMTCT and talking about the babies, you should never leave the infant unprotected. What do I mean? You should always have the mother suppressed or the infant must be on prophylaxis, right? And we're going to discuss that in detail next week. You should never have an infant who is not on prophylaxis and the mother has a high viral load, right? Whenever a mother has a high viral load, the child must be on prophylaxis. If the mother is suppressed, then we can stop the prophylaxis. And I think these are the things we're going to discuss next week with the follow-up. Lemo, you are saying, what if the same woman has TB as well as active psychosis? Yes, Lemo, you are right. Where there is TB, let me show you this particular diagram that I said you really need to like it because it's very loaded and it's helpful, right? Remember, if the mother has TB and psychosis, you won't be able to give efavirenz. Your options are then dolutegravir and lopinavir ritonavir. But if you give dolutegravir or lopinavir ritonavir in the context of TB, what must you do? You need to increase dolutegravir to 50 milligrams per Oz BD, or even double the dose of your lopinavir ritonavir tablets. So that is how you approach your cases all the time, right? And then I continue there. Richard, you are saying pregnancy, newly diagnosed, first viral load will be at 3 months. Yes. HIV positive on treatment and she falls pregnant during ANC booking, you do have, Brarich, you got it right. I think I'm happy with the way you have explained it. And maybe to go back, because I don't want to explain. I think there's a lot that we still need. And this is it. It says here, newly initiated on ARVs during the current pregnancy. You start here on ARVs and you do the first viral load at 3 months, right? If she comes in, she falls pregnant whilst on ARVs, during the pregnancy diagnosis, you must do a viral load on that day. The first day you see her, you do a viral load, right? And then Mpo, you are saying, yo, doctor, so no 6 months viral load for pregnant women. We were wasting government money with so many viral loads. Mpo, I'm going to repeat it again. If the 3 months viral load is suppressed, the next viral load is at delivery. If the delivery viral load is suppressed, then you do it 6 months after delivery. If it is suppressed, then you do it 6 monthly. When the child turns 24 months, the mother graduates from the PMTCT program and then they join the adult program. You no longer do your 6 monthly viral loads. You would then do your viral loads annually as per the adult program. So that is very important. Mafezi, you are saying, Esther, the dose of single DTG is 50 milligrams, but since the client is getting fixed dose, yes, thank you very much, Mafezi, for that. If you have a patient who's taking TLD and they develop TB, you continue the TLD the way they were taking it, you add the additional 50 milligrams. So if they were taking TLD in the morning with dolutegravir, you prescribe the additional 50 milligrams at night for DTG, and then your patient is sorted during that time, right? So yes, perfect. I see everyone is comfortable. All right. So yeah, so for today, I want to pause here, and then next week we are going then to continue to look at women now who are not being controlled, and then how then do we handle all those women. But I want to take any other questions that you might have. Do you have any other questions? Anyone who wants to raise their hand and ask questions? Yes. And Dogozo Madlala, you are very happy. All right, I'm happy if you are happy, but right. Anyone who's got a question? Yes, you may unmute. Nandi, you may unmute and ask. Then Mandla, you'll be next.
Hi, Doctor, and everyone. Doc, on the scenario of Maria, on the results there, the CD4 count is 250, and then creatinine, it's 90.
Yes.
So what do we do now that she is coming back at the 3 months follow-up? Do we continue with TDF, or we stop and give something else?
Nandi, when would you stop TDF in the context of a creatinine? When the creatinine is?
It's above 85 on pregnancy.
Yes, so what then would you do?
I think I will discontinue it and take the patient to Abacavir.
Yes, so there you are, right?
Okay,
so in the of pregnancy, if the creatinine is above 85, you would then stop the TDF there and then give your patient Abacavir and then your efavirenz, because she was initiated on efavirenz in this.
Okay, Doctor.
Right, yes.
Okay, Doctor, thanks.
Thank you. Who was next? Should I say Rabelani? Rabelani, are you okay?
Yes, Doctor. Doctor, I want to understand about that question of INH. Yes. I didn't understand you well. Okay, yes. Let's say a patient pregnant, before she got pregnant, and then we initiate on INH. And then after 5 months of taking INH, we tested her for pregnancy. So is that mean that she has to continue with INH, or do we stop?
You'll stop it.
We'll stop it even if she's already took it for 5 months.
Two things. Number one, if she falls pregnant while she's taking INH, you're going to check her CD4 count. If a CD4 count is below 350, you are going to continue the INH. Okay. If the CD4 count is above 350, you'll have to discontinue INH and maybe restart it again after the pregnancy.
And then we'll have to restart from the first one.
Yes.
Okay.
And the reason is INH for women with high CD4 counts, the risk of getting bad obstetric outcomes is too high than the benefit. So that is what we want to deal with. Yeah.
Okay, I understand.
Yeah. And then, Sai, you are asking, do all infants that are born from mothers who were on TB treatment during need INH prophylaxis? So Sai, they need to be assessed, right? The infant, when they are born, they need to be screened, they need to be assessed. If the child is symptomatic, that child will probably need TB treatment, right? If the child is asymptomatic and doing well, they might consider INH prophylaxis. You'll also probably need to delay BCG until at least they've completed either INH or TB treatment at that point in time. And Sarah, you are correct that the creatinine monitoring in patients who are on TLD is very important, you know. And if we are talking pregnant women, once the creatinine level crosses 85, we have to stop TDF. In non-pregnant patients, if the creatinine clearance is below 50, we have to interrupt tenofovir and consider abacavir. So I'm really happy about that. And then Lucia, EGK, yes. So yeah, there's a lot, Lucia, to cover, isn't it? That if you do a 3 months viral load and you did not write a code that tells the lab that this is a pregnant mom, they might not do the viral load. So you have to write hashtag PMTCT, you know, on the lab. I mean, it's hashtag CPMTCT. If someone remembers the code, they can type it in there, and then it should be very helpful. And Lindy, where you are saying viral load is detected 3 months after initiation. Yes, Lindy, for women who were diagnosed HIV positive during the pregnancy. You do it 3 months after starting ARVs. So that is very important. Mpo, you are saying, doctor, you are repeating your AFB since the patient is on TB treatment. Yes, when? I wish you were here to tell me, isn't it? You know, 7 weeks and 23 weeks as per the TB guidelines, you know. Mafezi is on top of these things. There you got it, 7 weeks and 23 weeks. All right. Yeah, one last question, and then we close the session. Yes, see hashtag PMTCT is the code you use when you do your antenatal viral load. See hashtag delivery for your delivery viral load. And I think there's also a specific code for your postnatal 6 monthly viral load that you need to use, right? Great stuff. Doctor, so exposed TB infant, we give INH prophylaxis and BCG. Esther, let me verify the issues about the TB exposed neonates, and then we will have some discussion about it next week. Yes, Sarah, you want to make a comment? Sarah, do you want to unmute? Sarah, are you there? All right. I think that's it for today, guys. May the good Lord richly bless you, and then let's then discuss again next week, same time. I want to keep it to an hour, and then we will talk about it. Yes, Mandla, you are right. To stop cotrimoxazole, you need 1 CD4 count above 200. All right. Thank you very much. May the good Lord richly bless you. Enjoy your evening. Bye.
Bye.
Bye, doctor. Bye.
Bye.